Now I will discuss on the management of anti-tuberculosis drug-induced hepatotoxicity. Treatment with first-line drugs is usually safe. The most common disabling adverse reaction is related to hepatotoxicity, which requires proper management. All anti-TB drugs might cause hepatotoxicity. However, certain drugs are likely more responsible than others for this adverse effect. The liver function test used for the diagnosis and the monitoring of hepatotoxicity due to anti-TB drugs are serum levels of alanine aminotransferase or ALT and aspartate aminotransferase or AST and the bilirubin. A mild transient elevation of ALT and AST might be observed during treatment and usually remains asymptomatic. Significant hepatotoxicity is usually symptomatic. Clinical features of anti-TB induced hepatotoxicity resembles that of viral hepatitis. Early symptoms include malaise, fatigue, loss of appetite, muscle and joint pain. Nausea, vomiting, abdominal pain are common in severe toxicity. Jaundice, scleral icterus, dark urine and discolored stool are signs of clinical worsening. Clinical hepatitis can be fatal and action should be taken immediately. When we see the general management of anti-TB induced hepatitis, first, patients with symptoms of hepatitis, we should have to stop all TB drugs and perform liver function test, especially liver enzyme and the bilirubin. If liver enzymes or bilirubin is 3 times upper limit of normal, we should have to wait for resolution of symptoms and perform liver function test weekly and restart TB treatment when liver function tests are less than 3 times upper limit. If this liver enzyme, AST, LDT, and bilirubin are less than 3 times of upper limit and mild symptoms, we should have to restart TB treatment, closely monitor the patient, and perform liver function test weekly. Continue TB treatment as long as liver function test levels are less than 3 times upper limit of normal and there are no signs of worsening hepatitis. But if a patient is not having a symptom or patient without symptoms of hepatitis but elevated liver enzymes and the bilirubin, if the liver enzymes are more than 5 times upper limit of normal or bilirubin is more than upper limit of normal by 3 times, stop all TB drugs and perform liver function test weekly. Restart TB treatment when liver function test return less than 3 times upper limit of normal. If AST and ALT are less than 5 times upper limit of normal and the bilirubin is less than 3 times upper limit of normal, continue TB treatment and perform liver function test weekly. If liver function test continue to increase after stopping TB treatment, then ongoing progressive drug-induced hepatitis should be accepted. So those patients who are on the first line of anti-TB drugs or on the drug susceptible TB treatment, in most cases, the same treatment can be resumed without incident, and the objective is to resume the initial regimen or alternative regimen as rapidly as possible. If symptoms reappear or liver function test re-increases after resumption, try to reintroduce the TB drugs one by one. Start with ethambutol and rifampicin and reintroduce isoniazid 3 to 7 days later. If ethambutol, rifampicin, and isoniazid have been introduced and the liver function test abnormality have not recurred, do not reintroduce pyrazinamide as it is the most likely the causative agent. The alternative regimen depends on the drug causing hepatotoxicity. If pyrazinamide is involved, isoniazid and rifampicin with ethambutol for 2 months and isoniazid and rifampicin for 7 months. For the total duration of 9 months should be given. And if the other drugs are responsible, for example, if it is rifampicin, treat as MDR or rifampicin resistant TB. So we should have to treat as rifampicin resistant TB to say rifampicin induced hepatitis. Thank you for watching. Have a nice time.